In the previous tutorial, we looked at PEEP and the work of breathing and the restoration of functional residual capacity. In this tutorial, we're going to look at PEEP and phasic shunting or phasic ventilation perfusion mismatch. We're going to look at PEEP and lung compliance and the problem of auto-PEEP and dead space. And finally, we will visit, for the first time, PEEP in ARDS. Tutorial 20. Hypoxic respiratory failure, Part 9. Why we use PEEP and CPAP, Part 2. Welcome back. Previously, I discussed CPAP versus PEEP and why they're ever so slightly different, and they're different principally because of the effects on pleural pressure. PEEP is used as a platform for positive pressure breaths. CPAP is for spontaneous breathing. We looked at PEEP and lung recruitment, and we looked at PEEP and lung volumes. This time I will discuss PEEP and phasic shunting, PEEP and lung compliance, CPAP and the work of breathing, and PEEP and auto-PEEP. This time I will discuss PEEP and phasic shunting, PEEP and lung compliance, PEEP and auto-PEEP, and CPAP and the work of breathing. PEEP and phasic shunting or phasic ventilation perfusion mismatch. Max is 64 and he was admitted to hospital with chest pain. He had a myocardial infarction and that was complicated by cardiogenic shock. He was treated with a percutaneous coronary intervention, a stent, but required an intra-aortic balloon pump after the procedure and then required vasopressors to get off the balloon pump. He was intubated and mechanically ventilated, and now some days later he's off vasopressors, but he's quite slow to wean from mechanical ventilation. You're at the bedside and the nurse informs you that Max's saturation on the monitor is reading 93%. However, that nurse had taken a blood gas just 5 minutes ago, and on the blood gas, the saturation of oxygen on hemoglobin, the SaO2, is 86%, with the PaO2 of 60 millimeters of mercury or 8 kilopascals. So there's a fairly significant difference between the pulse oximeter and the blood gas. 1 hour ago, the oxyhemoglobin saturation was 95% on the blood gas and the PaO2 was 80 or 10 kilopascals. Nothing else seems to have changed in terms of compliance, PCO2 or pH. There is no obvious atelectasis or pleural effusions on his chest x-ray. So what's going on? Well, I'll bring you back to this cartoon that we used in a previous tutorial, and this is likely what Max's lungs look like during inspiration. Now what I've drawn here is a series of airways and a series of blood vessels. Starting up the top, we have the airways that are the anterior apical segments of the lungs. These are the best aerated lung units, but they don't ventilate very well because air doesn't really move in and out. The posterior dorsal segments are at the back and in the bases. These are extremely well ventilated but not terribly well aerated, so they start at a low volume and move upwards. That makes them extremely vulnerable to collapse or to ventilation perfusion mismatch. In the middle, depending on where you are, towards the base is better ventilated, towards the apices better aerated. And finally, blood flow follows gravity, so blood goes downhill, so the posterior dorsal segments, depending on your position, are the best perfused. So the best ventilated and best perfused lung units are in the posterior dorsal segments. The worst ventilated but best aerated and worst perfused lung units are the anterior apical ones. Now, on inspiration, everything looks good for Max, but when Max exhales, this is what happens. And what happens here is his lungs de-recruit. There is loss of volume towards the bases of his lungs. From his mid-zone down to his lungs, there is a loss of volume, but blood continues to flow, so there is significant ventilation perfusion mismatch and shunt, and as a consequence, his blood gas is poor if it is captured at this moment in time. And that's probably what's happened. The pulse oximeter averages over maybe 15 to 30 seconds whereas the blood gas captures whatever is running through the artery at that particular point in time. So let's just run through that again. Inspiration, and then expiration, and phasic shunting. Inspiration, expiration, and phasic shunting. Well, what can you do about that? Well, this is one of the situations where PEEP can be really effective. So we're going to apply PEEP to prevent this basic shunting. And to simplify this teaching exercise, I'm going to simplify the picture. So working across from left to the right of the screen, you're going from anterior to posterior. That's why those lung units are slightly smaller from left to right. So the anterior apical segments are on the left, the posterior dorsal segments on the right. And in inspiration, everything inflates because the inspiratory flow opens up everything. There's no atelectasis, all is good, and you have great blood gases. However, in expiration, not so good. You get this collapse or poor inflation of the posterior dorsal segments and venous admixture. What we're going to do here, though, is we're going to give him PEEP. So here's our PEEP valve. We're going to apply PEEP, and we have a back pressure into those lung units, and let's see what happens. Now, as you can see, there is phenomenal phasic re-recruitment of the lung units in expiration. So those lung units which open up in inspiration stay open during expiration. So the saturation of hemoglobin is really impressive in expiration. Now, this does not come free. There is always a price to pay with PEEP. And one of the prices you pay with PEEP is you get pretty impressive inflation of well aerated lung units. So those lung units in the anterior apical segments that were well aerated previously are now slightly hyperinflated, and that is going to have a knock-on effect on the quality of CO2 removal. So this is what I really want you to understand from this section, the tremendous impact PEEP has on vulnerable lung units. When PEEP applied at end expiration, those lung units that would normally become very small or collapse or close or just have bad ventilation perfusion improves. Expiration without PEEP, expiration with PEEP. That's one of the real benefits of PEEP. So PEEP or CPAP prevents collapse of vulnerable lung units phasically during expiration. Low lung volumes compliance and auto-PEEP. Now let's visit auto-PEEP as a problem in the setting of low lung volumes. Here is our usual lung unit. It's our model of 3 zones. There's anterior apical, midzone, and posterior dorsal. You'll notice that this patient is receiving 5 centimeters of water of PEEP. The anterior lung unit is open to the airways, and the end expiratory pressure is plus 5 centimeters of water. The blood arising from this lung unit is well oxygenated. The second lung unit is obstructed due to junk in the airway or dynamic airway collapse, and there is gas trapped in there at plus 6 centimeters of water of auto-PEEP. Similarly, the dorsal lung unit is obstructed with 10 centimeters of water of auto-PEEP. The result is significant venous admixture with a saturation of 90% and a PaCO2 of 45 millimeters of mercury or 5.4 kilopascals. One thing to keep in mind also for later is that the mean pulmonary artery pressure is normally 15 millimeters of mercury, but in this setting of low lung volumes and gas trapping, it has increased to 20 millimeters of mercury. The application of 12 centimeters of water of PEEP in this setting will recruit all of these lung units, and this dramatically improves oxygenation. However, there is a significant increase in airway pressure relative to the pressure in the blood vessels that surround these airways. And those blood vessels are compressed, particularly in the anterior and midsections, and that is the principal reason for increased dead space. Now, you may or may not tolerate this increased dead space if your goal is oxygenation. The CO2 will go up and quite substantially. But also keep in mind that the mean pulmonary artery pressure will elevate, and this increases right ventricular afterload and it may result in reduced right ventricular stroke volume and hypotension. In this setting, administering norepinephrine to treat hypotension will worsen the pulmonary hypertension that has already been caused by hypoxic pulmonary vasoconstriction and PEEP, and it may precipitate right ventricular failure. Now that you understand these principles, let's map it all out on a volume pressure curve. This is our starting position where the patient has a lot of gas trapped in the airways at end expiration. It takes a lot of effort to open the collapsed or closed airways. In this scenario, the patient is on pressure-controlled ventilation with a PEEP of 5 centimeters of water and a driving pressure of 15 centimeters of water. In general, it's much easier to make inferences about the impact of PEEP, which is a pressure, by using pressure-driven modes of ventilation. So a tremendous amount of pressure is required to generate a reasonable tidal volume, in this case 320 mils. Note that the volume pressure curve is hysteric as usual, with higher volumes in expiration than inspiration. In this case, the PF ratio is 120 and the PaCO2 is 45 millimeters of mercury or 6 kilopascals. The dynamic compliance is 21 mils per centimeter of water. That PF ratio, 120, is quite low, so we decide to increase the PEEP to 12 centimeters of water. And now let's look at the pressure volume curve. Although on the surface this looks better, the tidal volume has only improved marginally to 350 mils, and the PF ratio has only increased to 140, with a dramatic increase in the partial pressure of carbon dioxide in arterial blood to 60 millimeters of mercury or 8 kilopascals. This translates to a compliance of 22 mils per centimeter of water. Not great. So what do? We drop the PEEP to 8 centimeters of water. Now let's look at the volume pressure curve. Well, that is stunning. The curve is so much better. With the same apparent driving pressure, we're now getting a tidal volume of 475 mils, resulting in better overall gases. The PF ratio is now 200 and the PaCO2 is a respectable 50 millimeters of mercury or 6.5 kilopascals. The dynamic compliance is 32 mils per centimeter of water. Why was there such a dramatic difference at 8 centimeters of water of PEEP? It's important to acknowledge that there may well be an optimal PEEP for patients with different lung diseases. We're looking for best oxygenation associated with lung recruitment, and clearly 5 centimeters of water was too little. We're looking for best ventilation that minimizes dead space, and clearly 12 centimeters of water was too much. But at 8 centimeters of water, the tidal volume improvement was spectacular. Why? Let's go back to this original picture. Look at these lung units. Gas trapped in the alveoli at end expiration. That is known as auto-PEEP or intrinsic PEEP. In any situation where patients are neither ventilating nor oxygenating, you must measure auto-PEEP, and you do this by performing a hold at end expiration. So let's do that for this patient. Here we have airway pressure on the y-axis and time on the x-axis, and I've put a dashed line at 5 centimeters of water of pressure. That's where the PEEP is supposed to be. So we're going to apply a expiratory hold to the pressure waveform. And here's the hold, and look at the way the pressure goes up. It goes up to 8 centimeters of water, and that is the total PEEP. The intrinsic or auto-PEEP is the total PEEP minus the apparent PEEP, and in this case the auto-PEEP is 3 centimeters of water. Why does this matter? Remember, we are using pressure-controlled ventilation. In this patient, we have dialed up 5 centimeters of water of PEEP, an inspiratory or driving pressure of 15 centimeters of water. The pressure limit that the ventilator will apply is thus 20 centimeters of water. The apparent driving pressure delivers a tidal volume of 320 mils with a compliance of 21 mils per centimeter of water. However, the ventilator does not know that auto-PEEP is there, so when it starts the next breath, all it wants to achieve is a plateau pressure of 20, and included in that figure is a hidden 3 centimeters of water of auto-PEEP. So the real driving pressure is 12 centimeters of water, and the real compliance is 26 mils per centimeter of water. So how did the moderate level of PEEP sort out this problem? PEEP and auto-PEEP. Let us explore one of the theories about how to manage auto-PEEP. Now, I've used a liquid here, a water, to describe this. And we're here at end inspiration, and the airway pressure, regardless of whether it is positive or negative airway pressure, incorporates 5 centimeters of water of PEEP or CPAP. As expiration progresses, airway closure occurs early in the cycle, and due to dynamic airway compression, gas is trapped in the alveoli at end expiration, and this is known, as we've already mentioned, as auto-PEEP. This results in 2 problems. 1, the airway pressure that is required to reopen this airway during inspiration imposes a significant additional work of breathing, and 2, the gas that is trapped in the alveoli is not refreshed and it becomes stale, low in oxygen and high in carbon dioxide. There are 2 ways that this problem can be overcome. Firstly, in inspiration, pressure support can be added to the PEEP, and this will reduce the negative inspiratory force that is required to open the airway and refresh the alveoli. By prolonging inspiration, as we will see in pressure control ventilation, the lung units can be stented open for a prolonged period of time. On the other hand, one may be able to overcome auto-PEEP by increasing the extrinsic PEEP. In this situation, we have increased the PEEP to 10 centimeters of water. Unfortunately, this is insufficient to overcome the airway closure-induced auto-PEEP, so nothing changes. Let's increase the PEEP further. Now you can see what happens with 12 centimeters of water of PEEP. You can see here that the pressure has now equalized, so the higher level of PEEP results in better gas distribution in inspiration and expiration. But at what cost? PEEP or CPAP that exceeds auto-PEEP improves airflow and gas turnover, but remember, it also increases dead space. PEEP and severe hypoxemia, as in the setting of acute respiratory distress syndrome. Lauren is 66 years old, and she has developed ARDS as a result of postoperative aspiration pneumonitis. Currently, she's on volume control ventilation, receiving 315 mils, an FiO2 of 0.6 and a PEEP of 10. Her PF ratio is 98. How much PEEP should we give her? One thing I will say from the outset is that nobody really knows how to set the optimal PEEP. Everybody seems to have an opinion, but nobody really knows. And nobody's even sure whether using high levels of PEEP is a good idea or not. There is some good reasons for using PEEP. PEEP protects against ventilator-induced lung injury. This is known as atelectasis, and I will cover this in detail later in this course. PEEP also improves oxygenation, but the big price you pay is that PEEP worsens ventilation and it causes hypotension. So the more PEEP you give, the worse the dead space to tidal volume ratio, and the more likely is you're going to need some form of vasopressor support to maintain perfusion of the tissues. And remember that vasopressors vasoconstrict the pulmonary blood vessels as well as the systemic blood vessels. So how do you decide? Well, it's difficult. There are lots of devices out there that are sold as a way of identifying whether the lungs are adequately recruited or not. None of these really pass the test of evidence-based medicine, but they're nice ideas. However, we should just talk about the traditional approaches at this point in this course. PEEP is traditionally set in 2 ways. One, you just set a goal of the best oxygenation you can possibly get, and you use a PEEP table that matches the FiO2 with PEEP. And this is derived from research studies, the original research studies. The ARMA trial from the NIH on ARDS from 2000 used a PEEP table that I'll show you in a minute, and lots of ICUs use that. You may have it in your own ICU, and there is nothing wrong with it. Alternatively, you can use compliance as your goal. There's lots of ways of doing this as well. The easiest way is you put the patient on pressure controlled ventilation. You start off at high PEEP, and then you progressively reduce the PEEP until there is a loss of volume. So the tidal volume for that level of driving pressure will just fall off a cliff at some stage, and above that is likely the best PEEP, and that's based on the idea that the lungs suddenly become compliant at a particular PEEP level. There are other ways of doing that slightly more scientifically by, for example, using a super syringe and titrating in volume and looking at the pressure in response to that. It's tricky to do. It's more a research tool, but it is a way of generating a quasi-static pressure volume curve, keeping in mind that every time you inject some volume, some of that goes off into the bloodstream. I don't do this in my clinical practice because I don't find it useful, and patients are often quite unstable. An alternative approach is to just look at dynamic changes in compliance with PEEP. So you look at the patient's compliance, and then you adjust the PEEP downwards and look at that. It's really the same as looking at the tidal volume, but it's sort of a nicer number. This is the ARDS-net PEEP protocol from multiple studies that were done over the past 25 years. And essentially what happens is if the patient is needing more oxygen, you give them more PEEP. And you can either give them a high level of PEEP or a modest level of PEEP, and it works reasonably well. But it's not hugely scientific because you're not necessarily looking at what's best for the patient. Can we use this protocol to sort out the PEEP issue with Lauren? Well, no, because she's already on the PEEP that is required by this propofol, 60% oxygen, 10 of PEEP. An alternative approach is to do a PEEP decrement trial. And what you do here is you change the vent over from volume control to pressure control, because you're essentially constructing a volume pressure curve, and you start off at a high PEEP, for example, 18 centimeters of water, and you look at the tidal volume, and then you look at the saturation. So you're looking at compliance and oxygenation. And in this case, you can see that the PEEP is 18, the tidal volume is 200, and the saturation is 86%. That's not great. And we're going to drop the PEEP in increments of 2 or more each time and wait a little while and then see what happens. And so if you do this, you can pause the video now and try and figure out what you think is the best PEEP here for Lauren. Well, this looks like the best PEEP here, isn't it? It's either 12 or 14. It might be 13. At 12, she has a tidal volume of 400 mils. This is pretty good. And her saturation is 94%. So she's oxygenating really well at this level. But at 14, she's a tidal volume of 480 mils, so better compliance, because remember, the driving pressure is still the same. We're using 15 centimeters of water, and her saturation is 92. So at 14, she's got better ventilation, but worse oxygenation. So you decide where you want to land, 12 or 14, or somewhere in between, maybe 13. But that's how you do a PEEP decrement trial. And of course, if you're working your way down to when you want to put them onto the appropriate PEEP, you need to do a recruitment maneuver and then put them on that level of PEEP. Don't let the patient de-recruit and then just stick them on 12 or 13 or 14 of PEEP, because it'll take ages for those lungs to reinflate. This is a picture that I used for many years when giving tutorials about PEEP and ARDS. And it's derived from a belief known as the open lung approach to mechanical ventilation, a very popular concept in critical care in the 1990s. I won't say that it's gone out of fashion, but just people don't talk about it as much anymore. And a lot of the research in this was done using that super syringe quasi-static compliance technique that I mentioned earlier on. The particular paper of interest was the Marcello Amato paper from 1998 that was done in Brazil in patients with ARDS. And it showed an improvement in outcomes by reducing the amount of stretch on the lungs and giving lots of PEEP. And what they suggested is that we try and build a pressure volume curve for our patients and look for the point where the lungs suddenly become compliant. And this is like blowing up a balloon. When you start blowing up a balloon, it's kind of hard. Then there's a sudden give, and then the balloon inflates much easier. That point on the volume pressure curve, they call the lower inflection point, or the P-flex. And if you keep on blowing up the balloon, there comes a point where it doesn't really inflate much more, and then it starts overstretching, it will pop. And that point they called the P max, so where the amount of pressure versus the amount of volume you got just didn't really do much. So that was the point where you really should stop giving any more pressure to the patient. So the P flex is the point where you would imagine is the ideal place to apply the PEEP level, and the P max would be the pressure limit. Over the years, the same group suggested that we really shouldn't be using a driving pressure of more than 15 centimeters of water, but that's another discussion. Nevertheless, this approach remains useful, at least theoretically, and a lot of people think this way, that there is an optimal PEEP and a point, P flex, a lower inflection point where the volume pressure curve really improves. So think about that when you're applying PEEP. Let's return to Lauren. Based on the PEEP decrement trial, a PEEP of 12 to 15 centimeters of water may be warranted. But keep in mind the pitfalls. There will almost certainly be an increase in the partial pressure of CO2 in arterial blood, a drop in the pH, and a drop in the blood pressure. You need to be sure that this is a lung recruitment issue and not something else that you can treat. For example, is this patient fluid overloaded? Can you diurese the patient? Can you recruit the lungs in a different way? For example, is there any reason not to turn this patient prone? And we will cover this in detail later on in this course. And have you considered increasing inspiratory time? That is, increasing the mean airway pressure rather than the PEEP. In summary, carefully titrated PEEP improves lung compliance, but excess PEEP worsens it and increases the dead space to tidal volume ratio. Let's review this tutorial. Initially in this tutorial, I discussed the use of PEEP to treat phasic shunting in expiration. We then went on to discuss PEEP and lung compliance and how it affects the volume pressure curve and the impact of auto-PEEP and how to manage auto-PEEP. We also looked at PEEP in severe hypoxemia and how you set PEEP, a subject that I will come back to in a later tutorial. Next time I will discuss CPAP delivery systems, heart-lung interactions, and the use of CPAP for heart failure. So that was our second tutorial on PEEP and CPAP. I hope you found that useful. In the next tutorial, we'll visit heart-lung interactions and the use of PEEP and CPAP to treat left ventricular failure. If you're enjoying these tutorials, don't forget to subscribe on YouTube, and of course you can follow me at ccmtutorials.org.